Hi, everyone, and welcome. Hope everyone's having a lovely Friday morning. We're going to get started here in just about a minute. I've still got a few people transferring over from the weight room. Well, it is February, which is pretty crazy to think that I feel like just yesterday we were just starting off another school year, another quarter, and now we're already into winter. So we're very excited to welcome back today Dr. Kevin O'Brien and Dr. Ruchi Kapoor with us from UW Medicine Heart Institute. It is Heart Month in February, so it's the perfect time to talk about taking care of our hearts, especially over the last few years. There's been a lot in the news around COVID and heart health, and heart health might be something we haven't been paying as much attention to with all the other health concerns that have come up the last few years. So we're very excited to welcome back Dr. Kevin O'Brien and Dr. Ruchi Kapoor, who have both presented for us in the past. We are recording today, so we will get this added up onto our YouTube within time. And just a few housekeeping things. Go ahead and send questions in the chat. If you'd like to wait, you can raise your hand at the end. We'll answer questions after both doctors present. With that, I'd like us to be able to have the full amount of time. So Kevin, I'm going to go ahead and pass it off to you. Thanks again for making time today.
Anna, thanks very much. I really appreciate the opportunity to speak, especially during Heart Month and with Valentine's Day on Monday. So my objectives are, first of all, to help understand why heart attack and stroke are equal opportunity diseases. Secondly, describe the symptoms of heart attack and stroke. And then finally, analyze why prompt recognition and treatment help to save lives. I also will say a little bit about concerns about COVID vaccination at the end too, because I know that's an issue. So this is Frank Netter, was a medical illustrator who back in the 40s and 50s developed really great books with his own paintings to show both anatomy and some depictions of different medical conditions. So this is the old 50s version of a classic heart attack patient, and coming out into the cold weather. He's clutching his chest. He's just eaten a big meal at the restaurant, and to clutch his chest, he had to drop his cigarette. So, but of course, this creates a false impression that there's a typical way that symptoms present with a heart attack, and that it's a male disease, not an equal opportunity medical problem. And so, in fact, here are the leading causes of death in the United States from the Centers for Disease Control for the year 2015. And for women, heart disease was the #1 cause of death, and stroke was #4. And for men, it's very similar, that heart disease is the leading cause of death in men as well. Stroke's down at 5 because men, the third leading cause of death in men are accidents or unintentional deaths, which is also kind of surprising, but maybe not if we think about it. So really, overall, if we look at heart disease and stroke combined, they account for 30% of deaths in both men and women. So what are how can a heart attack present? What are the symptoms of heart attack? Well, the first is that we describe chest pain as a prominent symptom of heart attack in men, but in fact, I think a better way of characterizing this is to term it chest discomfort. It can occur in the center of the chest. It typically does last more than a few minutes. It's not a temporary or transient thing, but it can. But most people actually don't describe it as pain. They describe sensation of pressure, squeezing, or fullness. And in addition, and particularly in women, that classic cardinal symptom of a heart attack is often not seen. And this accounts for some of the reason, and that is one reason that accounts for why women are less likely to present early with a heart attack than men. So in fact, men and women can have their initial symptom be really a discomfort in other areas of the upper body. The arm, most classically, the inner aspect of the left arm, the back. A very common location for discomfort in heart attack is pain radiating up to the neck or jaw. And some actually upper abdominal or stomach pain, discomfort is also frequently seen. Shortness of breath can also be a symptom of heart attack, and that can occur with or without chest discomfort. And some other potential signs are cold sweat, nausea, and lightheadedness. What about stroke? So the American Stroke Association came out a few years ago with this really helpful acronym, FAST, to describe symptoms of stroke. That's the F, A, and the S, but also to really emphasize the fact that recognizing stroke symptoms early is very important. So F is face drooping, A is arm weakness, S is speech, and then T is to call 911 as soon as you possibly can. They've actually updated that, though, to B FAST, to add a couple of other symptoms. So the B is balance. Is the person suddenly having trouble with balance or coordination? E is eyes. It was with a stroke. Some people will experience a suddenly blurred or double vision, or a sudden loss of vision in one or both eyes without pain. So painless changes in your vision could be a early sign of stroke. Face drooping. Does one side of the face droop, or is it numb? So if you, one way to make this more clear is to ask the person to try to smile. And if they're not able to raise both sides of their mouth equally, that can be a sign of stroke as well. Another one is arm weakness. Is one arm weak or numb? And what you can do is ask the person to raise both arms. And that's a very sensitive way of detecting whether or not they have some arm weakness. If the arm is weak, it'll tend to drift downward and to turn the palm in. Speech is another important symptom. Is the speech slurred? And that can be manifested as either the person having difficulty speaking or speaking in a way that's hard to understand. And so like arm weakness, a way to kind of elicit subtle symptoms of speech abnormalities are to ask the person to repeat a simple sentence. And then again, finally, T is time. That it's very, very important to call early if a person shows any of these symptoms, even if they go away, because we want to get the person to the hospital as soon as possible so that therapies can be given that can decrease the risk of disability or death. So one of the important, I think an important concept in both heart attack and stroke is that the longer the symptoms go on, the more damage occurs. This is a depiction of what proportion of the surviving heart muscle cells are present at various times after the onset of symptoms. And so you can see that really by an hour and a half, about half of the heart muscle cells in the affected area have died. And you continue to lose heart muscle cells out to 6 hours. So if we really want to save heart muscle cells, we want to get people to hospital and try to open up the blocked heart artery as soon as possible. And for stroke, it's even more, the time is even more important, so that by 3 hours, most of the damage has already been done. So in particular with stroke, we want people to be able to recognize the symptoms early and to call 911 in both cases. And how can we save heart and how can we save brain tissue? Well, in the case of a heart attack, we can take people to the heart catheterization lab, and a catheter can be inserted through an artery either in the wrist or the groin. And on those arteries, we have mounted a stent that can be opened up with a balloon to open up the artery and restore blood flow. In the case of stroke, there also, in some cases, at very specialized centers, it's possible to open up the artery to the brain with or remove the clot with a catheter-based therapy. But the most common and most efficient way of doing this is to be able to give a clot-busting drug called TPA. So that it gets infused through a vein, and it can go to the clot that's blocking flow to the brain and dissolve it. But the standard guidelines say that we need to be able to really maximize the benefit for a patient from clot busting in a stroke is to be able to get that medication into the patient within 3 hours of the onset of symptoms. So what can you do? Number one, you want to know that heart and disease and stroke are the cause of death in 3 out of 10 Americans, and that's true both for women and for men. Secondly, to recognize the symptoms of a heart attack, that the heart attack symptoms can present as a discomfort in the chest, arms, neck, jaw, or the upper abdomen, not necessarily pain. For stroke, remember this acronym of balance, eye or visual disturbances, facial drooping, arm weakness, slurred speech, and that it's as important or even more important in somebody having a stroke to get to the hospital as soon as possible, and activating the emergency medical system by calling 911. So in both, again, call 911, time is muscle or brain. Now, I wanted to show a couple of slides here at the end of my formal presentation to look at how the causes of death in the United States have changed in the last 5 years, particularly because of the COVID pandemic. So in both men and women, or in men and women combined, COVID-19 is now the third, or at least in 2020, and I'm sure that the statistics will be the same for 2021, that COVID-19 has become the third leading cause of death in the United States. So that the combined cause of death of heart disease and stroke is 26% instead of 30%. But that's not because people are having fewer strokes or heart attacks. In fact, they've been having more, in part because of reluctance or more death from those causes because of reluctance to seek medical care when symptoms develop. And in extreme cases, inability to get into the hospital when the COVID hospitalization rates have been very high. So I think the most important thing we can do to help decrease the risk of death and disability from COVID, which includes some risk of heart problems, both fatal heart problems early on and long-term heart problems in some patients, is to get immunized. But I know there's been a lot of press about this very rare complication of the COVID vaccines, which is developing myocarditis or inflammation of the heart muscle. So this is a nice CDC graphic that shows the relative balance of risk from myocarditis and the benefit from hospitalizations prevented due to COVID vaccination. And it is the case that in younger individuals, particularly in males, the risk of myocarditis is higher with the COVID vaccines. But let's balance that against the benefit of the predicted prevented COVID-19 associated hospitalizations in those who've received a vaccination. So you can see that the benefits clearly greatly outweigh the risks of myocarditis, especially in older people. So in summary, heart attack and stroke are the causes of 3 out of 10 deaths in women and men. Heart attack symptoms can include discomfort rather than pain. Pressure, discomfort describes as pressure, squeezing, pain, or shortness of breath, not only in the chest, but also some people can prevent with these symptoms in the arms, especially the left arm, the jaw, the neck, or the upper abdomen. For stroke, remember those symptoms with the acronym B, FAST, and to act now because time is muscle or brain. But also, it really, for your heart health and for your overall health, vaccines are good for you. And it's really important to, even if you've had this, the 2-shot series of the COVID vaccine, to get a 3rd shot. In fact, for our heart transplant patients who are very immunosuppressed and don't respond as well to the vaccines initially, we're actually having them get a 4th shot. But for the general population, 3 shots are really the way to go with that. So thank you for your attention. And I'll turn it over to back to Anna and Ruchi.
Thank you, Kevin. All right, and just as a reminder, we're going to save questions for the end. So Ruchi, I'm going to go ahead and pin you and let you take it away.
Thank you so much. Let me share my screen. Thanks to everybody who took the time on this lovely Friday afternoon to come meet with us. As it says up on the screen, my name is Ruchi Kapoor. I'm a general cardiologist here at University of Washington, and my clinic is actually based out of Eastside Multi-Specialty Clinic in Bellevue. But I also see patients usually in the inpatient side, so not a good place to be in general. But if you need cardiology care, I do see some patients at both University of Washington, the main Motley campus, and at Harborview Hospital, which actually I'm at Harborview right now. But I wanted to take some time this February to emphasize heart disease in women, because it's quite frequently underappreciated, and I'll kind of show you why. So, but I wanted to start off by kind of talking about what is heart disease, and quite frequently when we say heart disease, we really mean ischemic heart disease. The idea being that the heart is supplied by all of these wonderful blood vessels that supply blood to the heart muscle itself so it can do its job and pump. And there's generally, one major artery on the right, 2 major arteries on the left, but all of these arteries have further smaller branches that kind of really get in there and distribute the blood to the muscle. And this is, of course, an autopsy specimen, but in a live person who's having a heart attack, for example, that Dr. O'Brien talked about, we can do a procedure called an angiogram, where we go in and inject contrast dye into the artery and then really be able to take a picture on X-ray to see how the blood flow is through all these different arteries. So when we talk about ischemic heart disease, what we're saying is that the blood flow through these blood vessels is inadequate and insufficient to meet the demand of the heart. What the muscle needs, these blood arteries are not able to supply that amount of blood. And there's a few different flavors, so to say, of heart disease. But the main one that we most often see or talk about is obstructive or atherosclerosis, or stenotic lesions. Those are all different words, technical words, that describe that there is one blockage in the artery where it's very narrowed. And that's what Dr. O'Brien showed. We can go in with the same procedure with a contrast dye, but we are also now able to deliver a stent to open up a blockage. like this if it's causing symptoms, or a major heart attack, which is a complete blockage here. But we also have ischemic heart disease where it's not one particular localized blockage, it's more diffuse, sort of generalized narrowing. And this is a phenomenon that we see quite often in women. And treatment of it, oh gosh, I wish there was one, place where you could go in and put a stent in and open it up. But unfortunately, this generalized narrowing really doesn't lend itself to our traditional treatments for ischemic heart disease. The reason this is important, the differences between these different flavors of heart disease, is because about 50% of women who have symptoms of ischemia, meaning the chest pain, tightness, jaw discomfort, sometimes even blood tests that suggest there's been injury to the heart muscle because of inadequate blood flow. In those women with the signs and symptoms of ischemic heart disease, when we do the angiogram, we don't find a single blockage that we can go in and open up. More often what we find is that in these women who are having symptoms, who are having signs of ischemia, it's more related to the little tiny branch vessels that I showed in the initial picture. And it's because those branch vessels are either not able to open up completely to provide adequate blood flow. For example, when you're walking or exercising, your heart muscle needs more blood flow, and they're just not able to dilate or get bigger to provide that blood flow. Or it's because the same branch arteries are just too narrowed because they tend to spasm. And that can also lead to angina, which is the typical symptom of chest heaviness, tightness, or really any symptom that describes inadequate blood flow to the heart muscle. And this really, the disease is related to the branch vessels. It's the catch-all term is microvascular disease. And you may have heard that in the news or in the literature. Maybe somebody you know was diagnosed with microvascular disease. And microvascular disease really falls at this line of, before we see blockages, but really we've already started seeing symptoms related to abnormal blood flow. The risk factors for microvascular disease is similar to, macrovascular disease or obstructive coronary disease. And that's hypertension, obesity, hyperlipidemia. For women in particular, there is a role for estrogen. And so postmenopausal women tend to develop heart disease more often than premenopausal women. But also a big role for autoimmune diseases that really has a prominent role in developing subclinical before we can see atherosclerosis and kind of this microvascular disease. And women tend to develop more autoimmune diseases than men do. And we think there's a clear role for that. And one of the kind of underpinnings that I want you to kind of take away from what is atherosclerosis is that there is a role for inflammation in the body, and inflammation that leads to this abnormal function of the arteries of the heart. To kind of emphasize what Dr. O'Brien also said, cardiovascular disease, #1 killer in the United States. This is a paper that was published in 2019 in Circulation. And it's really combining in cardiovascular disease. We're really talking about heart attacks and strokes. So those two diseases combined are the #1 killer in the United States in 2019. I think we do have more recent data, but it shows very similar findings for both men in blue and for women in red. #1 disease, more so than cancer and accidents, diabetes, Alzheimer's, all of those. Compared to them, cardiovascular disease, #1 killer. And if you look at that trend of men versus women over time, historically used to be men died more often than women because of cardiovascular disease. But that trend sort of started flipping in the late 1980s and 1990s, where we made some, very aggressive changes, and we got some wonderful medications. We got treatments like the angiogram, the stents, and we're really able to make a lot of progress in reducing that heart attack and stroke risk in men. but we were not able to make the same progress in women until the 2000s. And then finally, the number of women dying from heart attacks and strokes started really declining until we kind of go back to the more recent years, where it's again, men more often dying. But overall, the trend has been very encouraging, where we've made some great strides in preventing heart attacks and strokes. But then you ask the question, why did it take us this long to make progress in women? Well, it's because women tend to think, oh, it's just a man's disease, or they don't make their own health a priority. A lot of women, they think, I'm not old enough to be at risk of heart attack or strokes, or I'm too busy. I have to take care of other people in my life. They're already very stressed or tired. All sorts of reasons why women don't really take care of themselves and their own heart health. And this study in 2012 was so telling, and it's just fascinating to me that on a survey, we asked women, if you thought that somebody else around you was having signs of a heart attack, what is the first thing that you would do? 81% of women said they would call 911. But if you rephrase the question as, if you thought you were the one who was experiencing signs of a heart attack, what is the first thing you would do? Only 65% of them would call 911. They're more willing to call 911 for there's somebody else that they're around. But for themselves, they would rather take an aspirin and just keep going with their day. So women tend to prioritize other people around them more than they prioritize themselves. And of course, the other issue is that when we talk about symptoms of a heart attack, as Dr. O'Brien mentioned, it's not always chest pain, but it can be pressure, tightness, heaviness. Sometimes it can just be a feeling of doom and gloom. Chest discomfort is still the number one symptom for women, as in men, but women tend to have a lot of other symptoms associated with it, or in place of it. So they can just feel nauseous or feel really short of breath. I saw a wonderful lady in my clinic just last week who is in her 80s, and her only symptom was just feeling so short of breath. She was at her granddaughter's soccer game, could barely walk from the bleachers stands back to the car because she just couldn't breathe. She didn't have any chest discomfort at all, was not nauseous, didn't have any back pain. Only symptom she had was shortness of breath. And she actually, turns out, had the same symptom a week before, but ignored it. This time she happened to be with her son, who is a paramedic, and is like, no, mom, you got to go to the hospital. And turns out she was having a heart attack and got a stent and is doing much better now. So just a reminder that women can have symptoms quite frequently other than chest discomfort. So it's pretty important to pay attention to what your body's telling you. The other thing that we should know in terms of men versus women is that women tend to do get heart disease at a later age than men, but it can happen in younger women also. They do have a higher risk of dying from cardiovascular disease. And it may be that they just tend to, as we saw earlier, they tend to ignore their own symptoms, present a little bit later to the hospital. And because their symptoms are rather atypical, it's not always that chest heaviness, maybe they're diagnosed a lot later. Women tend to be more hypertensive, have worse blood pressure control, are at increased risk of diabetes. They're at increased risk of developing heart disease. Let me rephrase. It's increased risk of heart disease from diabetes, increased risk of heart disease from having stressors in their life, and they're at increased risk of heart disease from obesity. So not that they have all of these risk factors more than men, it's just that these risk factors play a bigger role in women than in men. And when we talk about risk factors that we can fix, and certain risk factors that unfortunately we can't do anything about, I want to talk about non-modifiable risk factors first. Age. Unfortunately, we still haven't found the fountain of youth, so we can't reverse that. Family history. You're kind of born with the genes and the genetics that you have. We're able to treat some of those genetic risk factors like cholesterol, but the genes that you're born with are the genes that you're born with, unfortunately. Pregnancy, non-modifial risk factor. Autoimmune diseases, we can treat them, some of them, but unfortunately a lot of them are not. And radiation for cancer therapy. So this is a surprise for a lot of women, is that women, for example, who've had left-sided breast cancer get radiation, sometimes surgery and chemotherapies, and chemotherapies are their own risk factors, but radiation in particular, particularly if it's around the heart, can lead to increased risk of heart disease years, decades later. So we don't find out about those, about the heart disease for a lot of these patients until much later. But certain things that you can do that's in your hand is, if you're smoking, stop smoking. If you have high blood pressure, diabetes, cholesterol, those are things that you can work with your doctor, doing medications, lifestyle changes, whatever is needed to really get on top of those risk factors. Obesity is an interesting one. I actually would I know I put it in the modifiable risk factors, but I would put it somewhere in the middle. Obesity and that kind of waist, increased abdominal obesity in particular, it's so tied into people's body image that I think there's a tendency for people to modify it with these crash diets, fad diets. And unfortunately, a lot of those diets work for a short time, but they're not really long-term sustainable ways of reducing weight. So, so I think obesity is a modifiable risk factor in the sense that you can change your diet, you can change your physical activity and alcohol consumption, and all of those modifications will affect your weight. But and it is a risk factor for heart disease, but how much of that is under your control is a little bit up for discussion, I think. But ultimately, the take-home message from this slide should be that 80% of cardiovascular disease in women is preventable with controlling your blood pressure, diet, lifestyle, stopping smoking. If you're smoking, and if you don't smoke, don't take it up. But 80% of cardiovascular disease in women is preventable. There are certain other women-specific risk factors that I very briefly want to touch on. A lot of it related to pregnancies, because pregnancy is almost like a stress test on the body. So if somebody had preeclampsia during pregnancy or had gestational diabetes or hypertension, it's almost predictive that even if the blood pressure and sugars improve after the baby is delivered, it's a prediction that down the road, those things, the blood pressure and sugar, will come back or may come back. And so if you had any of these things during pregnancy, it's particularly more important to keep close eye on these going forward in time. Certainly, there's a lot of interest in research that's going on right now, and there is a wonderful OB-GYN doctor here at University of Washington who's starting a research project in looking at women who have heart disease, and if they ever had preeclampsia in the past. She's doing a study to figure out why preeclampsia is a risk factor for heart disease down the road. Other things in particular, oral contraceptives, especially in women who smoke, tends to increase risk of clots. Certain autoimmune diseases, as I mentioned, tend to happen more often in women. And I already mentioned radiation for breast cancer. And to, again, emphasize the symptoms of heart attack, chest discomfort is just one of them. Most often it's also shortness of breath, but just getting very sweaty and hot, fatigued, dizziness, nausea, body aches, any of these symptoms that come on suddenly, go to the hospital, call 911, take it seriously and pay attention to it. So certain things that you can do to help your heart moving forward, don't don't start smoking if you don't already smoke. And if you do smoke, stop it. A lot of people tell me, oh, I took up vaping to stop smoking, but now I vape, which unfortunately still has nicotine and is still also associated with heart disease. So replacing, one risk factor for another risk factor is not always helping your heart. So really just stop smoking. And there's a lot of resources that are available at the state level to help with that. Exercise. So our recommendation is 150 minutes of moderate intensity exercise every week. So that's basically like a brisk walk. If you go for a 30-minute walk 5 days a week, you are meeting the exercise goals. Now, if you can do more, that's always helpful. So this is a minimum, not a maximum. And the alternative to moderate intensity exercises in vigorous intensity. So that's if you're doing running, biking, something where you're really working a sweat up and really getting your heart rate up. If you're doing that kind of aerobic activity, then 75 minutes a week is a minimum. And alternating that with strength training, because bone health and strength training for balance is also very important going forward. Diet. There was actually, I gave a talk last week also for the Heart Institute on diet and its importance for heart health. So really emphasizing fruits, vegetables, and I really do mean fruits, not fruit juice. And instead of white rice or white bread, really focusing on whole grains where you get that extra fiber. And really doing a concerted effort to avoiding saturated and trans fats. So for example, this question came up last week, which is, oh, what about olive oil? Well, olive oil has a lot of polyunsaturated fats, monounsaturated fats. Those are heart healthy fats. And that's what the Mediterranean diet study showed us, is that some healthy fats are actually helpful for the heart. But really saturated and trans fat are not healthy for the heart at all. And really limiting your sodium intake, and all the nutrition labels now for foods at the grocery stores have, in the nutrition label, they show how much sugar was added to that food, and minimizing that added sugar as much as possible. Blood pressure, really, if you can, with lifestyle changes, with physical activity, low sodium diet, weight control, bringing that blood pressure below 120/80. For some people, we say under 130/80. The guidelines for the blood pressure do tend to vary from health society to health society, but in general, really being on top of blood pressure. And then optimum weight and waist size. As I said, this is a little bit kind of up for discussion on how much this is under your control. But I do say that if you follow a heart healthy diet and really engage in regular exercise, this will follow. But just moving forward for women, for really taking care of themselves, and actually for men who want to take care of themselves, know your numbers, know your blood pressure, know your glucose or A1C, know your lipid panel numbers, cholesterol numbers, and know your kidney function. People with kidney disease, for example, who are on dialysis, they tend to die of heart disease. Heart disease is a huge risk factor for heart disease. So know your numbers and know what you can do to really get on top of them and control them. Because 80% of cardiovascular disease in women is preventable if we can do all these things. This is the last slide I wanted to leave with, because I did briefly talk about diet and nutrition. And at the base of this is the cornerstone of having a heart healthy lifestyle is really being physically active and enjoying meals with others around you. But when you do have the meals, really emphasizing grains, olive oil, beans, nuts, legumes, seeds, fruits, vegetables. As I said, avoid fruit juice because you're missing out on a lot of the wonderful fibers and vitamins that come in fruit, the whole fruits themselves. emphasizing some component of fish and seafood at least 2 times a week. If you're vegetarian or vegan, know that there's a lot of plant alternatives for protein sources. But if you're not vegetarian, then really having fish or seafood at least a couple of times a week, and really de-emphasizing meats and poultry, eggs, cheese, yogurt, just because these come with a lot of saturated fat and cholesterol, and we really want to minimize them as much as possible. So really thinking of red meat in particular, and sweets and desserts, not saying no to them 100% of the time, but just knowing that, you know, they're treats, not something that is a component of every meal. And then wine is in moderation. And this has also been a little bit controversial recently, because we know that alcohol can be a toxin to the heart. It is associated with a whole host of other health issues, psychosocial issues. So the idea is not that we recommend it necessarily, but if you are somebody who drinks alcohol, then really drinking in moderation, and really water. Water should be your go-to beverage for everything. So I just wanted to end on that, and thank you, and give it back to Anna.
Thank you, Ruchi. That was great. It's always a good reminder. Go ahead and remove your pin so we can go ahead and get to the questions here. So go ahead, as we said earlier, you guys can start sending questions in the chat. If you have any, you're welcome to raise your hand as well. I'll keep an eye on both sides here. I'm just going to start going down with what we've got. So the first one that came in is, what is the risk of heart attack if someone consistently has low blood pressure but has diabetes? It is controlled. So, but what are those risks with diabetes for heart attack and stroke?
I don't know if Kevin, you wanted to take that one, but or I can also
Go ahead.
I mean, I don't have a number off the top of my head about the risk or risk of heart attack or stroke, but diabetes is an independent risk factor for heart attack and stroke. So, but if it's controlled with diet and exercise, that's a very good sign. So your risk of stroke, or I mean, not necessarily you, but whoever has diet controlled diabetes is at overall lower risk of stroke or heart attack than somebody whose diabetes is not controlled. And certainly low blood pressure is not a risk factor for heart disease.
Yeah, I agree with all of that. Put some statistics on this. So you're about 2 to 2.5 times more likely to have a heart attack if you have diabetes. And controlling your other risk factors is very important, in particular, controlling your cholesterol levels. So the recommendations for the bad cholesterol level at which to start statin drugs to lower cholesterol are to actually start earlier if people have diabetes and at a lower level than if people those people who don't have diabetes. If you're there are some great online calculators that you can use to actually see how treating to calculate what your 10-year risk is of having a heart attack or dying of a heart attack, to calculate it, and then by entering in your systolic blood pressure, whether or not you're on medications for high blood pressure, whether or not you smoke, and what your good and total cholesterol levels are. But then you can see how your risk can change if you are able to modify those factors. And of course, smoking is one of the things that they ask as well. So, I think you encourage you to potentially look up those. One of them's a Framingham risk calculator, and another is a pooled cohort equation calculator. And I could give those web links to Anna to distribute to the group. So I think, yes, you can definitely, your risk if you have diabetes, your risk is going to be higher, but it does help substantially to control those other factors. It's the relationship between trying to lower blood sugar levels and decreasing risk of heart attack is a little less clear in studies that have looked at that, but those studies primarily tried to lower blood sugar by using more intensive insulin regimens. And there's some newer medication